What happens if your sleep apnea appliance patient develops this posterior open bite while they're wearing a sleep apnea appliance, for example, the Somnomet or one of these mandibular advancement appliances? What do you do then? So first, let's talk about this. What is a sleep apnea appliance? Basically, sleep apnea appliances are just mandibular advancement appliances. They were developed in the late 1800s by Pierre Robin as well as Anderson, and later on in the 1930s by Emil Herbst. And these appliances have been used for orthodontic class 2 corrections for a very long time, for about 100 years. Now, they're being used for sleep apnea treatment because as they position the mandible forward, they move the soft tissue out of the airway, and patients can basically breathe better. So a lot of patients who have mild sleep apnea, they wear these appliances instead of a CPAP. Sometimes patients even with moderate sleep apnea will wear these appliances, and they improve their sleep apnea a lot of times. Now, why do people develop these posterior open bites? So let's talk about it. There's several reasons for that. As these mandibular advancement appliances position the mandible forward, if a patient has undifferential condylar cells in their condyle, and patients can have that even up to age 45, you can have bone deposition at the condyle, and a patient can have mandibular jaw growth. And actually, this was actually published by Panchers and Roof in the 1990s in Germany, and it's available in English too. But you can have undifferential condylar bone deposition at the condyle, and the mandible actually can get longer, and it can create a permanent bite change. Now, the second reason is you can have a TMJ disc displacement, namely anterior displaced disc with or without reduction, a lot of times without reduction when the disc gets stuck in front of the condyle, and then they can also develop these posterior open bites from that. So what do you do in these cases? So one thing I would do is, of course, encourage patients to wear the repositional appliances, but this patient hasn't worn that, for example. So now what you can do is you can ask the physician to maybe put the patient back on a CPAP if that's what they decide to do. It's up to them. And then what I would do, once a patient is on CPAP, you could put them on a deprogrammer. So hopefully if it's a displaced disc, the patients can get back into centric relationship, and then the bite can settle back to its normal position. I see that all the time. I treat a lot of these patients. You just basically have them on a CPAP, discontinue their sleep apnea appliance, and then put them in a deprogramming splint basically, and that will help maybe the jaw to settle if they didn't have that differential bone growth and the condyle that I talked about earlier. If basically the bite settles back into normal, which usually happens anywhere between 4 to 8 weeks, then you're good. Then all you have to do is just basically keep the patient on CPAP per the physician. It's not up to you, but the physician can keep him on a CPAP, and then you just they just basically never wear the sleep apnea appliance again, and they kind of back to normal. Now, what happens if it doesn't settle back into a normal bite and they still have a posterior open bite even after they have worn a deprogrammer? If that's the case, then you can have two issues for that. They can have a more like a permanent anterior displaced disc without reduction. You can diagnose that from an MRI, not a CT, but an MRI. So you have to get an MRI in a open in a closed jaw position. And the second reason why they can have that posterior open bite even after they have worn the deprogrammer is if they have that bone deposition at the condyle, and you can diagnose that by a cephalometric X-ray. So usually what I do in those cases, I order an MRI without disclosing agent, and I order it in an open and a closed position both, and then I order a report from beam readers, and they can tell you if the condyles are normal as well as if the patient has a displaced disc from the MRI. If the TMJ disc is normal and they don't see anything on the MRI, then you take a cephalometric X-ray, and actually I take it at the same time. And then unfortunately, the only thing you can have is sometimes these patients need jaw surgery, mainly maxillary advancement. And what's going to happen is the surgeon is going to do a Lefort 2 and bring the maxilla forward. That usually doesn't happen. It's only maybe 5% of the cases, but then you can settle the bite in really nice. Usually with only a Lefort, sometimes you have to do double jaw surgery. And I just had a patient like that. We just finished her case a couple months ago, and then you can get the bite really nice and settled again. But if they had mandibular bone deposition at the condyle, basically the mandible got longer. Now you need to match the maxilla to that, and unfortunately, that's the only way you can fix those cases. Luckily, those are rare cases, but those cases need the Lefort surgery. And a word of caution, you're going to be very careful with these sleep apnea appliances, especially when you have a class 1 patient who's younger than 40, especially if they're younger than 30. If they're younger than 30, they probably have undifferentiated condylar bone cells in the condyle, and if you position the mandible forward, they will have differential condylar bone deposition and jaw growth. You can research this by that article by Panchers and Roof. If you DM me, I can send you the article. There's a lot of MRI studies on this. It was published in the late 1990s. 1990s, and you can read about it there. So you have to be careful if you have a young patient who have sleep apnea, you're going to make them this mandibular advancement appliance and they're class 1. I recommend to all of my students not to make mandibular advancement appliances for class 1 young patients under 30, because you will have this problem sooner or later. If you treat 100 cases, you will have about probably 10 to 15 cases end up like this if they're that age group and they're class 1. So it will be better to use these appliances if the patient is class 2, because if they have any, basically any condylar bone growth at the conda, that would actually just help their class 2 and the bite will actually get better. And I had examples for this, and if you want to see those, I'm happy to send you those links too. But be very careful with the sleep apnea appliances with class 1 patients on young patients under 30. Hopefully you found this helpful. I teach orthodontics, TMD, and sleep apnea treatment for general dentists, periodontists, and specialists. We have an orthodontic mini residency, as well as I have online courses for treating patients with TMD, idiopathic condylar resorption, as well as sleep apnea. Sorry, I'm at the gym, so that's why you have this background noise, but I wanted to comment on this Facebook post because I get these questions all the time, almost every single day, so hopefully this was helpful.